Our next and last speaker is Mark Bishop from University of Florida. He's a great character in the world of physical therapy. In the international scene, is also renowned. It has been working as a physical therapist from the last 25 years. He has an award of the Association of Physical Therapists in America. He's a very cherished character, and it is a pleasure for us to have him here.
Esto es mi segundo tiempo aquí en Sevilla. Me gusta mucho. ¿Sí? But I will not torture your ears for very much longer with my bad Spanish. And in fact, I don't speak Spanish. In Florida, we speak Spanglish. ¿Entiendes? ¿Sí? A little bit of Spanish, a little bit of English. Now, I have to come completely clean about this talk. We've heard so much really good stuff today that what I was going to tell you, I think, is a little bit boring. So what I would like to do, with your permission, is do that really annoying thing where people skip over their slides, say, oh, I don't want to talk about that, I don't want to talk about that. Because what I think would be really useful and what I would like to talk about is how we are applying some of the stuff that we heard today in our chronic pain clinic in Florida. I would like to kind of give you that information. So if that's okay, that's how I'm going to proceed. Bueno. Right. The other thing I need to do is tell you that hardly any of this stuff is mine. It all comes from our collaborative group. We have a very active research group in Florida working with chronic pain, and these are some of the participants in that group. I will later tell stories about Mike Robinson. Those people who were there yesterday already know those stories, but you can hear them again, I think. So I called this Engaging the Brain because, as we've heard today, that's pretty much where it all happens, right? What I would like to do is spend time about how you can go back on Monday and engage that brain with your patient straight away. Originally, I was going to talk about psychological processes. That's the part I'm going to skip. I'm going to briefly talk about some psychological models and then get straight into the meat and potatoes. You know that saying, meat and potatoes? It means into the grunt of the talk. So Steve Linton did a nice review in Physical Therapy Journal of psychological processes in 2011. And in general, most psychological models have these components. Specifically for pain, the way this would fit, according to Dr. Linton, is that pain grabs your attention. That's something that really engages these cortical processes. You then, associated with this, have cognitions, which are the way you think about your pain. We know that there's emotions associated with pain, and the combination of all that is what generates the behavior that brings that person to see you. Now, some of the very common models that have been described are listed up on the board there. I think most people are familiar with the fear avoidance model or have heard something about fear avoidance. But other common models are acceptance and commitment, misdirected problem solving, and then two that I hope to get to today, which is self-efficacy, which is a more positive sort of model, and then stress diathesis. So this is the part I'm going to kind of go fairly quickly through. Fear avoidance model of the fear kind of keys your attention to the painful stimulus. That's one of the important components of the model. This is a cartoon, a figure of the model that kind of shows how, or tries to explain how two people can have the same injury and end up with different outcomes based on how they think and what emotions they have associated with their pain. Acceptance and commitment talks about those patients that you might have that desperately think there's a solution to their problem. In that particular sort of model, you kind of would be working with the person, or the psychologist would be working with the person to kind of redirect their cognitions and their beliefs to allow them to attain more appropriate goals. Misdirected problem solving is kind of the patient who has been to see several different people. They think there has to be a solution and they're trying to solve this solve this solution of their pain. The primary underlying or underpinning part of this model is that the person thinks there is a definite cause and they're searching for that definite cause of their pain. I put this figure in here because I like it a lot. It's got lots of arrows and boxes and looks very complicated. But really it's remarkably similar to the fear avoidance model in its structure. So, self-efficacy. In self-efficacy, attention really isn't emphasised very much, but the cognitions are the beliefs related to control. Right? We talked about, or heard someone talk about that this morning, about whether you can control the pain or control what's happening to you while you're in pain. There's not a lot of information about emotion in this model, but the behavioural sort of ramifications are related to coping, how the person copes. Self-efficacy itself applies to just about everything you do. Self-efficacy is the belief that you can do that task. Low self-efficacy, in contrast, is accompanied, particularly in pain, by the belief that there is nothing you can do about it. I don't know if it's correct, and I'll get some of the psychologists in the room to help me here, but in my mind this reminds me of helplessness. There's nothing I can do about this pain. High self-efficacy, on the other hand, is a feature of people who are able to manage their own pain. Right? I already showed you that. So, to show that this is actually important in the work that we do with people with chronic pain, low self-efficacy in people with chronic knee pain is characterised by that feeling of the pain being unmanageable. In contrast, high self-efficacy has been associated with higher levels or lower levels of pain and disability in people with chronic arthritis of the hip and knee. In general, people with medical conditions or chronic pain, when they're being managed in a cognitive behavioural model with psychology, are encouraged to adjust habits and lifestyles. And it requires efforts for the person to understand the nature of the problem, education about self-care, and having that person learn how to overcome their problems effectively. The way that you and I can do this is by asking the person about their self-efficacy. And I know this is in English up on the screen. There is a Spanish version. But this is a very simple, short questionnaire that in our practice is just part of the intake packet. Does that make sense? The forms that the patient fills in when they come to see you. And this can give you an idea about high or low efficacy and how they really feel about managing their pain. Now, self-efficacy, it turns out, if it's high, is a positive, very positive affect thing. I think in the chronic pain literature in physical therapy, we've spent a lot of time focusing on negative things. You know, we know a lot about fear, I think. We know a little bit about anxiety, but we don't really think about the positive things. What are the things that stop people from getting to chronicity? What are the things that help people get better? I think, or we think in our group, that self-efficacy could be that thing. Self-efficacy has also been shown to actually mediate changes in pain intensity and disability in patients with chronic disorders all over the place. Elbows, necks, backs. I happen to work with back pain a lot, so I'll probably tell you stories about back pain, but know that this can apply to just about everything. So, what can we do as physios to do this? Well, when we're interacting with the patient, we can provide our advice and treatment in such a way that takes the patient's preferences into account. It involves the patient in the decision making, and you can provide the person with useful self-management information. Now I'm just going to talk now about patient preferences because it's related directly to expectation and placebo that we heard about just before. Patient preference is part of what's called collaborative decision-making. Have you ever eaten at a buffet? You know what a buffet is? Meal where all the plates of food are out and you walk around with your plate and you take a little bit from each thing. In Spanish? Buffet. See? So I think about, in that cartoon part of my brain where I imagine things, that collaborative decision-making is like a buffet. I ask the patient, what do you think is going to help make you better? What do you want to do? Here's what I want to do. What do you want to do? And we can reach an agreement about how that program's going to progress. The patient preference for treatment is directly related to their expectations. The expectations are very, very broad, but in general for physiotherapy, they've been kind of defined this way as predicted, ideal, and normative. Ideal, well, that's out of sequence, isn't it? Ideal expectations are actually what do you want to occur? They're like hopes and desires. Normative expectations are what you think might actually happen. Right? You see the difference between a hope and what you think might happen? Generally, these normative things are related to satisfaction with your care. How should I act as the therapist? Did the clinic have parking that I could get to? There's lots of these normal expectations that people have. We think that expectation and placebo are very, very strongly linked. So I'm just going to reiterate a little bit from our talk before that placebo is not nothing. Placebo is an active and very, very powerful thing that we can actually enhance in our patient care. There's many, many studies related to placebo. One of my favorites is in folks with Parkinsonism who get deep brain stimulation. And in that particular experiment, they actually, I'll come back to that one. This one up here on the screen's the sham, the transplant. The outcomes related to the transplant were based on which group the patients thought they were in, not what they actually got. In the deep brain stimulation study, they had surgery to put electrodes into their brain, which is pretty serious to me. And they wear a little device and they can turn it on and off to stimulate the basal ganglia. And in this study, it didn't matter if the device was on or off. It only mattered if the patient thought it was on. So when they thought it was on, even if it was off or unplugged or just wires, they walked great. As soon as they were told that it was off, when it was on, they shuffled again. So that to me is a pretty incredible sort of powerful mechanism going on in the brain if you can overcome those type of performance and functional deficits by just telling the person that it's on. Other great studies are the sham cardiac bypass, sham arthroscopies, sham alcohol. How many people have been undergraduate students before? Yeah, me. I volunteered for lots of alcohol studies when I was in college. Yeah, 1 credit to drink beer in the afternoon, that sounds great. But there was always these sham alcohol studies where they would give you amber-coloured liquid and tell you it was beer. The effects, I got to tell you, are pretty similar. Cheaper too, if you ask me. We also know that placebo has a massively robust effect on pain, and it happens through biological processes. We heard a lot about cognitive processes in placebo before, so I'm not going to dwell on these. Some of the powerful ones are activation of the same pain relief network that is activated when you're receiving actual medications. Opioid pathways are involved. It's actually somatospecific, so you can cause a placebo in one place, like in one patch of skin. And just that patch of skin receives the placebo when you put the medication back on. It's actually dose specific. We do these experiments where we give you 2 pills instead of 1 pill. If you get 2 pills, the effect is much bigger. We also have a very special cream called trivaricane. So that's got to be better than bivaricane, right? So when you put trivaricane on a patient in a placebo experiment, it works so much better than bivaricane. I mean, it's an incredible response. I'm actually going to skip to this part now about how can you assess patient expectations. There's a couple of ways. Mike Robinson, the redhead psychologist from Florida who gets mad when I give talks that have psychology in them, he developed something called the Patient-Centered Outcome Questionnaire. It actually was developed for patients in chronic pain, and you ask the person, what is your usual pain? What would you really like it to be? What do you expect it to be? And so you can kind of see whether the person's expectations are potentially realistic. They have 70 out of 100 pain but want to walk away from you with 0 out of 100 pain today. You can think to yourself, oh, I have a little talking to do, I have a little work to do to tell this person that may not be the outcome today. It's also been modified so you can do it for any patient, not just someone with pain. Actually, a colleague of mine, Sergio Romero from Cordoba, who's at UF now, developed this one. And so this is one where you can ask the patient, what do you want to change? Do you want to get more mobility? Do you want more energy? What are the things you want to work on while you're here with me? A very simple clinical application, because I'm way too lazy to do the long questionnaire, so I do this very simple one where I ask the person, what do you think is going to significantly help this episode of pain? I don't know if you can see any of those words there, but this is actually a list of things that people think they will help their back pain. So right here, we've got strengthening, stretching, manual therapy, exercise, and you'll see that, oh yeah, that's much easier, isn't it? So here we've got stretching, strengthening, manual therapy, exercise, and you can see people think those are going to help. When I ask patients, what do you think are going to help? They think these are going to help. Oh, that's good. That's very good for me, because I want them to do that. Down here, they say, oh, but I want a massage, I want some traction, I want to rest. If they're the things they want, they're not really part of my treatment plan, but I need to talk to them about how we might be able to use those. Was anyone here yesterday in the talk in the afternoon? A couple of people, so you're going to have to hear this all again. One of the things the way I use patients' preferred treatments that I don't think are going to work very well, like a massage or ultrasound, I use those as a reward for a job really well done in therapy today. So you've done all your exercises, this is better, you tell me that you're feeling better, great. I'm going to reward your positive behaviour with something that you really want. And so that's how I incorporate it into my practice. I'm sure there's 100 different ways of getting patient-preferred treatments into your treatment plans. The good news for me is I always want them to do some sort of strengthening. I do a lot of manual therapy because that's my background, so that is good that patients expect that to help. Some other things that really work that you can start doing on Monday are building patient-therapist alliance and working on how you deliver your instructions. So therapeutic alliance is that thing that you all know about. It's the bond between you and the patient. It's the trust that the patient has in you. And so there's ways to actually speak with the person to get them on your side. Certainly including what they want in treatment is one way to do that. And therapeutic alliance has actually been shown to be a really important variable in outcome in clinical trials. Only about 5 years ago did people start including therapeutic alliance as a measure in their experiments. Say, oh, I got this great result from acupuncture in back pain. But when you tease apart the results, it turned out that the people who get better from acupuncture are the ones who, like acupuncture, had a good therapeutic alliance with their therapist. May or may not have been the acupuncture itself. For instructional set, I'm just going to take a minute. One of the things I like stories, so I'm going to tell you a story here. This is an experiment that we did about 10 years ago. And do you know what irritable bowel syndrome is? IBS? Well, there's a treatment for IBS where they stick a balloon in your rectum and blow it up. That's an actual treatment for IBS. And so we did an experiment where we got volunteers, actually, which is another thing to think about. We got volunteers in this experiment, and because we wanted to know how much does it hurt someone without IBS. And so we put the balloon in just without anything, pumped it up, put the balloon in covered in lidocaine gel. Oh, that's got to make it feel a little bit better. And put the balloon in covered in just lubricant. And so over in this part here, what you can see, here's the natural history, the balloon without anything. Here is the balloon with lubricant, and here's the balloon with lidocaine. Great. Lidocaine worked really, really well. But because we had a graduate student who wouldn't listen, helping us on this experiment, she actually said to one of the patients, oh, this really helps some people. And so we replicated her result, or her experiment, and when we told people who were getting just lubricant, this helps some people, look what happens. The lubricant does better than lidocaine. So when people thought they might be getting this thing that's going to make some people better, every patient, most patients assume when you say that, oh, I'm going to get the thing that's going to make me better. And so we were able to actually outperform lidocaine for pain relief in this experiment by modifying the instructions. The challenge with this, though, is that you can actually make people worse with your instructions, and that was the nocebo effect that we heard about earlier. In this particular experiment, we actually told people that what we were going to do might make them worse. And so when we asked people, oh, I just told you that this might make you worse. Do you think you're going to be worse? Oh, yeah. Yeah, they did. The people we told, oh, this might make you better, yeah, I'm going to be better. So that's what they believed. Then we did manipulation on these people with back pain, and wouldn't you know it, the people who thought they were going to get worse got worse. The people who thought they were going to get better got better. So just that simple instruction reversed the outcome of our treatment for these folks with back pain. Now, what I'm not advocating is that you say, this treatment is the very best treatment, it's the fantastic, if you do this, you'll be 1,000,000 times better. But I am saying you need to think about your delivery and say, this is a treatment that works very well for some people. That's all you have to say, and just saying that simple thing can change some of these physiological responses very easily. Actually, just another story. The way that I use that in my particular practice is I've asked the person, what is it that you want? I think for your back we could do manipulation, I know this other manual therapy technique, we can do exercises and something else. Which one of those do you want to do? And they say, well, is the one better than another? I say, well, I like manipulation. I'm really good at it. But you don't have to do that. The others all work just as well, and most people get better with one of these treatments. And I say, oh, okay. Well, I'll do your manipulation then, or I'll choose exercise. And so that's how I kind of incorporate this process into my patient management. Right? The next thing I need to bore you with is this stress diathesis thing that I have a bee in my bonnet about right now. And in the psychological models, there's not much, in the attention dimension of psychological models, there's not much attention in this stress diathesis. But it actually is a model that considers these catastrophizing thoughts, self-efficacy, avoidance, so it's kind of bringing a lot of these models together. And initially it was proposed in the 80s to explain muscle hyperactivity or muscle spasms in people with pain. However, more recently, Dennis Turk started thinking about how this might be related, thinking more about emotions and stress, anxiety and other types of distress. This model is at the core of efforts to refocus back pain management to secondary prevention. Another thing I like a lot, where we can actually get people when they're in acute pain and stop their pain from progressing. So briefly about stress. You have stressors, they're the things that make you stressed. And then you have the stress response. Now, everyone in here functions on a continuum somewhere between the sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system is responsible for getting things going. It's the fight or flight, right? So it catabolizes tissue, gets glucose working, increases arousal, kind of like this. So when faced by the saber-toothed tiger, that man is going through an acute stress response. What's happening? Well, what's happening when he goes through that acute response is his amygdala signals everything, and that actually causes stuff to vasoconstrict, gets him all sweaty, a little bit like me going through my acute stress response, a room full of people watching me. That response is actually pro-inflammatory, right? So it makes things more inflamed, that initial response. But after that, the amygdala activates your HPA axis, your hypothalamic pituitary adrenal axis, and that releases cortisol. And once you get that cortisol in your system, calms it down a little bit, and it turns out that cortisol helps get glucose to the tissues, but it decreases inflammation. All right, so I'm going to come back to this idea of cortisol decreasing inflammation. If you're chronically stressed, it means that stress system gets turned on and turned on and turned on. That ends up with unmodulated inflammation. So does that make sense? So if you lose that cortisol response when you're chronically stressed, now you've lost the ability to control how much inflammation is in your system. There's some speculation that this is associated with conditions that have widespread pain, chronic fatigue, IBS, fibromyalgia, that these folks might actually have some sort of cortisol dysfunction. So what can you do about this to find out from your patient about their stress? This is another very short questionnaire, and it asks things about stress in everyday life. The stress I'm talking about is work stress, marital stress, got to get your kids to school but be at work type of stress, just general stresses in life. What we have started doing is anyone who scores over 20 on this scale, we start addressing some of their daily stress as part of our treatment program. We give them advice about exercise if they're not exercising. We do some mindfulness stuff, which is regulation of attention, stopping them focusing on the pain so much, giving them strategies to kind of refocus onto other things. And then we teach them relaxation exercises, the idea being that we're trying to eliminate their stress response. I like this cartoon. Here's all the options for what you can tell people on Monday to do about their stress. Relax, read a book, but do your home exercises because they're important. So what I guess I'm trying to say here is that the things that we learned about today about placebo are important in everything we do, and you can use those on Monday by thinking about what the patient expects to happen and getting their preferences for treatment. If you can engage the patient in that treatment process, you enhance their expectation of outcome. You enhance that expectation of outcome, you start to get to use I call it the jelly, you start to get to use the bowl of fat up here to cause better outcomes. You can engage that brain to kind of change the physiology of the body. The second part is if you're not asking people about how stressed they are, start. It seems to have a really big influence on outcome. We have another story, last story, second last story. So one of the things you don't care about, but I'm going to tell you, is that the US government pays me to take perfectly healthy people and give them back pain. How's that for a job? I mean, it's perfect. And so one of the things we've found is that stress, before we give them the back pain, most of these are university students, so we like to kind of get them around exam time. So if we give them back pain during exam time, their pain is much, much worse. And it turns out that stress is actually, at least in our experiments, really strongly related to how much pain and disability people have after we give them back pain. Now don't worry, they only have back pain for like 96 hours or something, so it does go away, it does go away. It's not like I'm crippling Americans. What else should I say? What else? Oh, one other thing I want to talk about. One more story. One of my stories. As I was thinking about what Dr. Apkarian was saying this morning about changes in grey matter and structural changes in the brain, and one of the ways that I have kind of thought about these structural changes in the brain is that one thing we might be having to try and do is help people unlearn stuff. And when I think about that, actually if I ask you to think about what's 3 times 3? Hopefully most people are going, 9. So you've learnt that. How do I teach you to unlearn 3 times 3? How do I change that structure? And so if that's what we're facing with these patients in chronic pain, it seems to me that we need to do a lot of education and a lot of relearning and a lot of practice of normal activity and lots of stuff so we can kind of reverse some of these structural changes that Dr. Apkarian's been identifying. Just my opinion, of course. With that, I'm done. Yeah?